Good morning, everyone. So, Melissa Gare has given me the honor to introduce you, Janaki. So, welcome everyone to this session of Lox and Learning. Today we have Dr. Janaki Kuruppu, who is born in London, England, to an American mother and Sri Lankan father. She has lived in the UK and in Sri Lanka, but most of her life in the United States, and for the past 30 years in Maryland, with connections in multiple parts of the globe. She has always been fascinated by the similarities and differences in perspectives as influenced by culture and history. A mentor many years ago called her a world citizen. Since 2000, she's worked in multiple countries, mostly in Africa, as an infectious disease physician, working with local healthcare providers to develop HIV treatment programs, and also volunteered in 2015 in Sierra Leone during the Ebola outbreak. She currently works at the National Institutes of Health, focusing on clinical research in HIV and COVID-19. I don't know why it doesn't say that you're a Torah reader at Beth Am. That's important to me, at least. So your talk is titled, How Do Faith and Healthcare Work Hand in Hand? And we are so lucky to have you this morning.
So that was my topic, or my title, I guess, months ago when you guys asked me to send something, but my thinking about it has totally evolved as I've been just kind of thinking about this. And so we have, oh, there's Melissa there. Yeah. So these names.
If they share their faces, we'll see them in the room.
Indeed, indeed. So I actually know I have some ringers in terms of kind of what I've been thinking about in terms of this. So yes, some of you know me, some of you don't know me. I don't know some of you. I recognize some faces. And I used to, well, I still actually belong here. I think I still pay dues. And I do, as the rabbi said, I do come up here and read Torah and do other things. But I currently am living back in Rockville and belong to my other synagogue, which is also affiliated with some of, at least a couple here. So I was born in England, but I'm American, but I also have a British passport. And my parents were from two different countries. And so as I mentioned, or as I provided, when I was a teenager, I was having lunch with a friend of my mother's who was very eclectic and Californian. Okay, so the other piece of my personal history is that I grew up primarily in California. And in California, has anyone lived in California? Not just visited, but lived there? Nobody has lived there. Okay, so
How long do you qualify live?
How about longer than a year? Nope, okay. So California, for those of you who haven't lived there, which I don't know if anyone in
lived there for more than a year.
Okay, great. What part of California?
The Bay Area.
Oh, me too. Okay, so Palo Alto, yay. So I lived in California, actually Southern California and Northern California, which are, if you know, and Joe, if you know the Bay Area, you know that we have very different affiliations. So Northern California is the cool place to be, and Southern California is the not cool place to be from. But I did grow up early on in Southern California, and then spent most of my life in the Bay Area, until I left for school, and then I really haven't actually lived back there, but so I've lived here in Maryland now, I realized as I was writing that up, for 30 years, which is actually almost exactly half of my life now. And I don't feel like a Marylander, but I'm kind of guessing, show of hands, who was born in Maryland? Yeah, you guys stay put. So there's obviously a few people, and I don't see hands over there, but there's some people who were born elsewhere. I know you were born in Louisiana. Paul, New York. Other? Florida.
The Rockies.
Oh, cool. So you're, yeah.
Cooler than Palo Alto.
Ooh. Ooh. Okay. Others? New Jersey. Okay. Oh.
Melissa was born in Minnesota, she said.
Oh, that's cold. So I guess as I'm thinking about this, one of the things that I experienced, and I guess the other question I'm curious about is, and I know I have my ringers, but who has worked overseas somewhere? Oh gosh, I love this. Okay.
I'm not sure if it counts.
Oh,
I was a volunteer in Woods as a dentist for a summer.
sure.
Okay.
And sorry, where?
Which kibbutz?
Oh, in Israel, I'm sorry. Sorry, no. I can't get that particular. I have been to Israel, but I don't know all the kibbutzim. And other folks? Yeah.
Guatemala and Bangladesh.
Ooh. And?
I was in Kenya and East Coast.
Oh, nice.
Israel, Germany, and India.
Nice. Distribution, Sandy?
I worked on a kibbutz in 1959.
Wow. Wow.
It was the thing to do.
It was the thing to
Teenagers.
do.
Or young people. It was
Okay.
the thing to do.
I have in the chat Switzerland, England, Italy, Israel, Tunisia, New Zealand, Australia, Scotland.
Excellent.
And that's only 4 people.
Wow. Others?
Yeah, we know each other, but I worked in Eswatini, Kenya, Uganda, lived in Jamaica, worked all over Africa, and other places, Asia. But not live, but worked all over.
No, but work is,
all over.
yeah.
Asia. And all over.
Yeah, many of those minus age. I mean, we've been in agencies.
Anyone else? All right, so my first experience of working as a physician, there's a dentist in the room. Any other medical folks? You're a dentist, right? No. Oh, you're the dentist. Sorry. And you're? Oh, yay. Pediatric infectious disease, very different entity than adult infectious disease. And any medical folks? No? Okay. So when you train as a doctor in the United States, which I did, actually, which is why I'm here on the East Coast, I went to GW. You learn a very specific, and I'm sure this is true for other disciplines as well, but I can only speak to what I know. So you learn a very specific, kind of almost ritualized way of thinking about health. And there's there's a longitudinal understanding of what your health state is, what your genetics are from your parents, what you expect to die from, or not necessarily die from, but what you expect might be in your future in terms of health challenges. So, people who have breast cancer in their family might expect that they have a higher risk. Well, they definitely have a higher risk of developing breast cancer. And so they tend to screen for it and watch for it and that kind of thing. So one of the challenges, my first experience of working as a doctor overseas, and of course I traveled, I was born in England, and then we lived in Sri Lanka when I was 4 until I was 6. So and then I came to the US as a 6-year-old, and then formed kind of an American identity clearly. Every time I say, yes, I'm a British citizen, people are like, oh yeah, roll their eyes, because I definitely don't sound like it. But when PEPFAR, which was President Bush's emergency plan for AIDS relief, came into being, it was after many years of quite a few of our administrations being very unwilling to deal with HIV in places where it was really decimating the population. And for those of us who lived through the entirety of, well, pretty much all of us in this room are old enough to have known what it was like in the 80s. And, it really was amazing how bad HIV was when it first hit and we didn't have treatment for it. Now, everyone's very blasé about it. And pediatric infectious disease actually is a struggle, and those who become infected as teenagers are kind of shocked, that they could get infected, because I remember one young guy here, I worked in Baltimore, which is actually in some ways like another country. Like people in Baltimore, especially in the inner city of Baltimore, I used to hear, gosh, they've never gone out, like going to the county is like a big deal. But this one kid that came as a 19-year-old, newly infected, HIV positive young person, had said he didn't think he could get infected as long as he didn't have sex with anyone over 40. And this was in 95. So, it's this idea that, it's this old thing that as long as I don't have sex with people that are older, then I'm fine. So we have this idea that, okay, if you are going to treat HIV, our experience was in the mid-90s that you needed to have that longitudinal understanding of healthcare. You needed to have connection to a clinic. You needed to have medical records. So when I went to South Africa initially, which those of you who've worked in other parts of Africa, the second country I went to was Uganda, and people would say, oh, have you been to Africa before? And I'd say, yes, I worked in South Africa. And they'd say, oh, that's not the real Africa, which in many ways is true. But I did go to South Africa in '99 as part of the NIH. This was actually before PEPFAR, which was in 2003. So the NIH worked with the CDC and also with the South African National Defense Force. So and it was actually DOD was involved in that as well. And the idea was, as those of you may recall, at the time, President Mbeki was buying into a mythology about HIV not being caused by a virus, but being caused by AZT. Actually was a really interesting notion that would be a cause. And other ideas about poverty and that, it was kind of a big scam from the West. And so they were not dealing with the fact that there were a lot of people getting infected with HIV, and who gets infected primarily with HIV if you're not injecting drugs that are contaminated with the virus is people who are having sex, which typically is going to be people who are in their reproductive years, younger folks, and that is highly represented in the military. So the South African National Defense Force was recognizing that they had this big problem of a lot of their able-bodied, very important personnel being infected with HIV. So NIH and the CDC went over and worked with the South African National Defense Force, and we were setting up clinics there. And again, it was bringing an idea of medicine that was more longitudinal rather than what I've seen in many countries, and many of you may have seen as well, which is just that a lot of folks who don't have integrated systems of healthcare will have very episodic interactions with a clinic. So you walk in, and mostly a lot of the countries in Africa have been educated along the British system, so they call their clinics surgeries. And so you go to the surgery, and you might or might not carry with you, in many countries, you might carry with you a little stapled collection of forms called Form 5. They're pink. I don't know if they still exist, but it would be a little piece of paper which would have been written on by a doctor and nurses at one of those other episodic times that you went in to be cared for. And you might have had diarrhea, you might have had a cough, you might have had fever, you might have had malaria, you might have had any number of things. And you were given a prescription, and it was all written on that Form 5. You would take that Form 5 over to the pharmacy, and you would get your prescription filled, and you would get treated, and then you just have this sort of little pseudo chart that you were carrying around with you. Nothing longitudinal at all, nothing looking at, you guys go to doctors, and what does the doctor know about you? Well, the doctor knows about your family history, and the doctor knows about your birth history if you're a pediatric patient, and your doctor knows about all the things that you have been through, whether you've had your appendix out, whether you've had, allergies to medications. None of this stuff is recorded in those types of interactions. So, and diagnostics are limited as well. So this was this big challenge in terms of how do you treat HIV that really needs to be treated on a continuum. You have to go and you have to stay on your medications regularly. You have to have a supply chain that's going to provide medications in a consistent way, a reliable way. You can't run out of medications. So that was really what PEPFAR was about doing, was creating this both structural infrastructure with which to provide care and also to supply medications. So one of the well, we had a lot of challenges, and one of the things that I think was particularly challenging was that you had folks coming in from outside and saying, this is how you're supposed to do it. And I think that is fraught with challenge. So where I've been thinking about this in recent times now, having worked in, well, let me finish a little bit, and I'm like totally going to lose track of time because I didn't even remember to put my watch on. But in 2015, I had this different experience of going to Sierra Leone. So those of you, probably everybody is very aware of when we got really hysterical in this country about Ebola. And Ebola is a really incredibly severe disease. It kills half the people it infects. Kills. Okay, so we just went through a pandemic with COVID, which has a fatality rate, actually, fortunately decreasing now. It's a much milder disease. Who in this room has had COVID now? I actually haven't. I am COVID naive. And let's do it the other way around. Oh, thank you. Perfect. Who's actually COVID naive? Woohoo. Not bad, actually. Pardon?
It helps to be a hermit.
Right. Indeed. And actually, I'm really impressed, and I have my mask there, and I am used to wearing my mask all the time because I work in the NIH, and we have decided now. So one of the cool things, or not so cool, I have to say, because I really hate masks, is that the flu rates and RSV and parvovirus and all of the viruses that cause winter colds and illnesses went so dramatically down during that first year where we were all locked down that the NIH and I think many hospital settings have basically said, okay, well, we're just going to wear masks all the time forever, particularly because we have immunocompromised people in our population that we don't want to infect. And that's been, I guess, an advance. It's such a funny thing because, 20 years ago when the first SARS epidemic came around, and it was primarily in Southeast Asia. And so then we would see after that folks who, I saw it a lot at the NIH actually. We have a lot of Chinese and Japanese scientists who come and they would be wearing masks. What is that weird thing that, these Chinese and Japanese folks who wear masks, why are they so, are they germaphobes or what? And well, guess what? We're all now wearing masks because surprise, surprise, despite the beginning of the pandemic, words of wisdom, masks do actually help. Sorry, my tangential thinking. So the fatality rate of COVID, even at its worst, it was about 12 to 20%, depending on kind of where you looked. So Ebola killing half of the folks that it infects, and the infectiousness, this was from sweat even. So we had, I went over actually near the end of the epidemic there. So I didn't actually work sort of in the trenches. It was a bit of a complicated story in terms of how I ended up going there because I belong as an infectious disease physician to the Infectious Disease Society of America. And throughout, that epidemic started when in April, I think 2014, April or May. And during the summer, the numbers were going up and going up and going up. And there was the infamous first patient in Texas who had come from that area. And I guess it was Liberia. And there was a Liberian community there. And so there was a lot of angst about whether this was going to, tear through the United States. In the end, we had a handful of cases and a lot of panic. I got emails from IDSA, the Infectious Disease Society of America, for months of saying, we need volunteers, we need volunteers. I don't know whether you got similar queries. And it was, I remember vividly a date don't remember the exact date, but it was in October of that year. And NPR, which I listened to avidly, was quoting the WHO saying that they expected there to be 10,000 deaths by January of 2015. And it was rapidly escalating. And I thought, oh my God, I've got to do something. And that very same morning, I get to work. I was on my way to work up here, actually. So I have a long commute, used to have a long commute, and I would listen to NPR. And then the first email I opened was another of those emails from IDSA saying, we need volunteers. And so I clicked the little button in their little email, and I signed myself up onto their list. And I ended up getting paired up. So it was this weird little clearinghouse of infectious disease physicians matched to various organizations. And as it happened, I ended up pairing up with Paul Farmer's Partners in Health. Paul Farmer wrote Mountains Beyond Mountains about his experience as actually a family practice doctor setting up clinics in Haiti. And Partners in Health has been all about setting up infrastructure, which is actually kind of cool from my point of view, because by that time I had worked in a lot of places where the key problem was infrastructure. And and Partners in Health had never been about emergency response. So they launched themselves into emergency response. And I have to say, if you're not an emergency response organization, you probably don't do it very well. I don't know if anyone else has had experience with this, but it just so happened that I hooked up with them, and they did have a great organization in terms of mobilizing and going places, but they definitely didn't have what Médecins Sans Frontières has, which we were working with closely, Doctors Without Borders. Those folks, they know their stuff in terms of emergency response. And I had worked with them also in Kenya with PEPFAR, so we've been kind of associated with them or I had been associated with them, but not working closely with them. But all that being said, so October, I put my hat in the ring. January, they actually contacted me and said, can you go in February? And it was like, I have a clinic, I have attending months at the university hospital. I need a little bit more time to like sort things out. So as it happened, they ended up sending me in March. So I went in March to Sierra Leone. And by March, the numbers were declining. We still had an Ebola treatment unit, ETU. There were many sprinkled around. I went and I did work in one of them for the first of the 6 weeks I was there. I will tell you, it was quite eye-opening. We had set up a clinic with a lot of blue tarp as walls over like reused lumber with a lot of rusty nails sticking out in various places that did not look like they were safe, even without the whole issue of like a bloodborne or really all bodily fluids borne illness like Ebola. But we set up in this unoccupied school, and it was actually a very nice setup. One of the deals with Ebola is that you want to make sure everything is unidirectional, and so we had this kind of U-shaped thing where you would go in, you would don your personal protective equipment. Sorry, I shouldn't step out of the way like that. And then you would go and actually. So one of the interesting, not so great. And I'd actually been already trained in all this PPE in University of Maryland, because we were also expecting an onslaught of patients at the university hospital. We never had a single one. We set aside an entire unit, and we trained a whole bunch of us on donning and doffing our personal protective equipment, and we never actually saw a single patient. So we had a lot of money spent, which kind of appalls me actually. So we had tons of supplies, and we were all set up to take care of all these Ebola patients that we were going to have. Total waste of resources. But at any rate, so and when I was in Sierra Leone, we were struggling with resources, so that was kind of a problem. But in winter here in University of Maryland, putting on like multiple layers of PPE is fine because it's cold. Sierra Leone is like 90 to 100 degrees ambient temperature just with regular clothes on. And then you put on an entire hazmat suit. You have gumboots because you're sloshing around in bleach to make sure that you're not spreading the virus around. You have 3 layers of gloves, not just 2, but 3 layers of gloves. You have a hood, you have a face protector, and they wrote the time on your arm that you were checked out. Oh, and they put tape around your wrist as well. So you're basically in this little incubator. So somebody in their spare time there calculated that we've got to 150 degrees within 45 minutes. So you had the time written on your arm, and then you had to be out of there and doffed in 45 minutes, because you can't really function at 150 degrees. Some of the nurses actually, they had imported some vests that had little pockets to put ice packs in. And I never actually tried that because I don't like ice on myself, but because I'm very cold sensitive. But some of the nurses were packed with ice around their trunk to try and stay cool. So anyway, the very first day that I went in and worked in the ETU, we went around, we saw all our patients, and I was, just getting introduced to some of the patients. And there was this girl who was 10 years old, sitting on a chair like this, actually just outside one of the dorm areas that we had patients in. And so we had these classrooms that had multiple beds set up. And so there was a women's kind of dorm or ward, I guess, and a men's, and there were the kind of more severe and less severe. More severe, of course, being that we had oxygen concentrators, because that's all you have. I mean, we didn't have ventilators. We didn't have really anything much. We had barely IV drips and things like that. Nothing that was, anything close to what you would have here. So this young girl is sitting there and she's panting, and she wasn't looking very happy. The PA who was introducing us to all the patients said that she was actually on the mend, that she was recovering, but unfortunately her mother had just passed away and was lying, the corpse was lying on the bed inside the ward. And this poor little girl was sitting outside. She was panting and she was crying. So it was kind of hard to know whether the panting was just because she was so upset. So we went around, we sort of comforted her as best we could. The death team was going to be coming very shortly to take this girl's mother away. That was kind of another unidirectional. So half the people that would die would get carted up and go out this one area and off to the government, because that was, as I'm sure you all read during the time, a big deal in terms of the cultural practices and burial rites that were unfortunately, we all know here that burial is a very poignant and emotional experience, and it was very, very difficult to have this team of completely PPE suited folks carting off your loved one's body. But at any rate, we finished our rounds. We were at the end of our 45 minutes. So this was about 15 minutes after I'd met this young girl. And all of a sudden, so we were in the process of doffing, which took about 15 minutes. It took a long time to get everything off because they sprayed you down with bleach, and then you would take off the layer, and then they'd spray you down with bleach again, and you'd like wash your hands with bleach, and then you'd stomp your gumboots in bleach. There was a lot of bleach all over the place. But we suddenly heard folks calling for the next team. So it was this constant rotation of us going through in 45-minute increments. The next team went tearing over to this poor young girl who died within 10 minutes of their recognizing. So we had said that she needed some medication, and by the time I was actually out of the doffing station, she died, which was just extraordinary to me. So and this was something that was seen quite frequently, actually. And we also saw it a bit with COVID too, is that people coming out of thinking that, you're beyond the critical period, then succumbing to, and in her case, it was probably a secondary bacterial infection. So at any rate, that was, to me, a huge wake-up call in terms of, ooh, this is the real deal. I will just say one other thing about that particular experience, and then what I did want to do, well, let me finish this one little story. So in our group, we had one individual who contracted Ebola. And it caused quite a scare, actually, among the folks who were in our team. It ended up meaning that, so this person, and I have to be very careful about, like, I can't say anything very specific about this individual, but this person had been in morning rounds in the ETU, so sitting in pretty close proximity with 8 people total, I believe. So those 7 other folks ended up having to go into isolation for a period of time and get tested, which was a real problem because they were kind of key to our functioning. This person basically had developed headache. This was a Monday morning, and had fever and then collapsed. And one of the other funky things about Ebola is that when you're in a traditional medical setting and someone collapses, you go and you provide assistance. Right? You like immediately rush to their side. Well, you're actually taught, and it's enforced a lot as an Ebola situation, that no, you cannot do that. That is that instinct that you have to go and help someone. You've got to go and get all your PPE on before you can actually go and help someone. And in fact, we just recently, because of the Ebola recrudescence now in Uganda, we've been preparing at the NIH for the possibility that we might have Ebola patients again. So again, we're doing the same exercise that I find a little bit offensive, to be honest, that we spend a lot of time and energy preparing for something that probably won't ever happen. But we went through this whole thing. They've got a whole unit there that's totally empty, but they're training nurses daily to deal with Ebola if it should come. And they've been doing exercises where they have somebody mimic fainting. And then what do you do? Like, how do you manage that? So you don't go and immediately take care of the person, but you do put on your PPE and you have like this whole handoff situation. It's all very complicated. At any rate, so they had to deal with this person collapsing and then actually getting diagnosed with Ebola, getting sent to one of the ETUs. Ours was actually in the process of closing because we didn't have enough patients, so they were consolidating. And my work ended up being largely in the district hospital, trying to help restore some sense of normalcy in a hospital that basically had lost all of its personnel. When I got to that hospital, Port Loko District Hospital, which that was the only thing I was going to think about bringing slides for, but because it's kind of cool. Any of you who've worked in hospitals in sub-Saharan Africa, they're mostly outdoors, as are a lot of schools, and there were like dogs and chickens roaming around among the wards, which doesn't strike someone with a Western training as such a great idea, but it was what it was. And anyway, so we had basically staffing with nursing students. We had nursing students. We had actually no medical officer. There was a medical officer. So a medical officer is someone with training that's kind of along the lines of a PA here. So MOs, and then there are MDs, but the MDs are few and far between and mostly in the big cities. So we had an MO who would come around, was basically going to various district hospitals on a rotation throughout the week. So he was at our hospital one day a week. And so while I was there, I was sort of the doctor with a lot of pediatric patients, which made me really, really nervous. I don't like doing kids. And the one nurse who had survived was Sister Rebecca, the midwife, who delivered hundreds of babies in full PPE constantly. I don't know how she did it, but she also didn't get Ebola. And so she survived. So anyway, we had our personnel, our volunteer who contracted Ebola. Around about the same time, there was another medical officer, not the one who was touring around, but another medical officer who was working at one of the ETUs, a local doctor, who also came down with Ebola. Our American volunteer got express airlifted out to actually the NIH and got extremely high level care. Their local doctor was taken care of by one of the MSF, Médecins Sans Frontières, ETUs. Got very good care, but again, in very unresourced circumstances, did survive. But the sense was, and I think fairly so, that this was not fair. You have, and in fact, there was a certain sense that the person who got airlifted out, our person, kind of may have been involved. There was a doffing incident on the Friday before the Monday with this particular person, with kind of just a mistake that was made, which probably happened all the time, which is probably why so many of the healthcare workers got ill. But there was a bit of a sense of, these stupid Americans, they come and they don't follow directions. We have kind of a bad rep, to be honest. And our local doctor, who's been in the trenches, for months now, instead of just for 6 weeks, doesn't get the same level of care. So that's been a struggle for me. And what I wanted to do, I guess with the last 15 minutes, I don't know if any of you, so this is kind of a California thing, I guess. When I was growing up, we used to do these exercises of kind of, well, it was done in the context of meditation, but I sort of like to do it, and it's kind of nice the way the tables are seated, in terms of your identity. So my personal feeling through the experiences I've had, and I'd love to have folks share, but you start with a certain identity, which oftentimes is defined by family, exactly. So like the first place that you get, you're a kid, the first identity is defined by your family. And then you go out a little wider, and what would be the next circle? School, neighborhood, exact faith community, and that might be maybe a little broader. I suppose those kind of, which is the encompassing circle, is going to vary depending on where you grew up. So then outside of that, what's sort of the next affiliation maybe? Village, city, community. Then you've got exactly. So then you've got country. And when I was a kid, I don't know if others have this experience. Like I read tons of books. I was infatuated with Russia, but I just, no matter how many books I read about Russia, no matter how many films I see about Russia, and you see these gorgeous displays of Moscow and the cool turrets and things, I still kind of, in my mind, I have this kind of internal map of the world, and Russia is like a black area. Like I see it, I don't see it as a real place. I admit that. It's someplace I have not been, and I'm seeing a couple nods. So yes, maybe other people have that experience. And before I went to the continent of Africa, which is of course not a country, before I went to Africa, Africa was also like this black kind of no man's land. It was just sort of this thing on the map. But then you go and you're like, I have people, I have friends. In fact, at that district hospital that I was at, I was looked on, oh man, that medical officer, he did not like me for the first week. The first 2 weeks, actually. He resented the fact that I was there. He resented the fact that he thought I knew more than he did, which I think by the end of 6 weeks there, well, he was we've got these great pictures of us arm in arm because he decided that I was okay. So I guess I convinced him that I didn't think I was like little Miss American know-it-all. But you have friends, you have connections, you have you've actually, felt the earth and felt the weather and it becomes real. And so, now to me, Africa, it has, well, parts of Africa anyway, I haven't been to all of it, but parts of it have reality, tactile, it exists. So you have your country identity. And I think if you haven't been outside the country, then you sort of stop there, right? And to my mind, it's problematic that we do have these defining borders. So what I thought we could do, now it's down to 10 minutes, but I thought if we just, and maybe the group online can they
Yep.
talk? So I thought it'd be cool to sort of share our senses of what our defining identities are. And it's also, as you look over your life, when you were a kid, and I remember doing this in high school and thinking, wow, what kind of identity did I have as a Palo Alto high school student? But now, later in one's life, one has a different sense of sort of where one is. So I thought maybe we can share those circles for 10 minutes and maybe 8 minutes and then come back and share a little bit. So since I know where one is. So I thought maybe we can share those circles for 10 minutes and maybe 8 minutes and then come back and share a little bit. So since I know most of the people
I've written about him.
were past.
I did an article on him.
We're coming back.
So, we had a really interesting conversation. Hello. Oh, yay, and we see faces. Hey, hello. So actually, because you guys are so remote, I wonder if anyone from online, are they able to talk and we can hear them? Yes. Woo. Would anyone like to share anything they learned in their discussion and sharing?
Well, one item came up in our discussion when you were going through the various connections that we formed in life. One that you admitted was our work life.
That seems to be certainly at this table, it seemed like everyone went someplace or had connections because of work or avocation. Is your work art?
Yeah.
Oh, so work. Yes. And I'm seeing nods here too. No, okay. So the exception in the back. What was your?
Yeah, so we didn't talk about work at all.
Oh,
we
yay.
talked about where we're from
Uh-huh.
and how we identify now. And we were particularly talking about the hyper-local identities that we develop based on the neighborhoods where we live and where we actually travel. We also had a very interesting conversation about the difference between traveling through a city like Baltimore in a car or on a highway versus traveling through walking or public transit.
certainly, my little knowledge of living in Baltimore, which is a sum total of 2 years in 2 neighborhoods, but also working for 2 decades in Baltimore, the neighborhoods in Baltimore are just so distinct. But did that table have something, or yes?
So, just share what I said. So I just said that I was uncomfortable with the assumption that identity can play a role consciously in my own life, because that there's a positive aspect to it. But there's also the negative aspect in that you're reacting against things that are outside of your control. So I'm Jewish, but I lived in Virginia, and I no longer could be Jewish. I became a Jew. And so my identity was one of advocating for my safety and my protection, but it wasn't something that I consciously thought about in the way that I interacted with people. It was more, are they going to find out? What is their reaction going to be? And so if you open that and broaden it to other aspects of society, there's an assumption that there's culture and that we're all participating in it equally, but we know that's not true. And so some people's identity, like when they walk out of the house, is not the same as my own. So that when I walk into a 7-Eleven, I have certain identities that are important to me, but how I'm perceived by another person means that I have some agency because I'm a middle-aged white guy. But we know that isn't afforded to everyone in Baltimore City, so that when I say I have a Baltimore identity, it's neglecting the fact that Baltimore's identities are multiple, they're hierarchical, and some people have more agency than others. So I simply just said I was uncomfortable with the sort of premise of the idea that identity can be geographical or existential in a way that I had choice. And so it wasn't a criticism. It was more.
No, I understand.
Because I also work with people's identities all the time because I work in interreligious dialogue. So I often hear people's stories, but people forget the dialogue part, in that we're also informed by our encounters with others. And so I threw it out there.
You don't look middle-aged.
I'll be 50 minutes.
Wow. Just out of curiosity, do you wear a kippah all the time everywhere you go?
Not anymore.
Ah.
I grew up in a fairly Orthodox setting, and then I stopped being Orthodox. So then there were assumptions by my own religious community about who I was and who I was going to be, without me having to say or think anything, because I was reacting. Right? Maybe it wasn't as devastating as you thought it was. Right?
Interesting.
So I wasn't really the author of my own path all the time.
Yeah, the part that really resonated with me, I'm really glad you brought it up, was just the idea of identity is not something we can always choose, you know? We can have all kinds of ideas about who we associate with, but often we're not seen at all by those things, and that affects who we are and how we see ourselves.
Well, actually, that was something I was going to mention about growing up in California that I totally forgot as I was like being.
You're off camera.
Oh, that's true. But that's okay.
Back.
I'm back. So none of you guys have lived in California, but you were late. What part of California?
So I was born in Orange County and lived there when I was like a baby.
Okay.
And then our family relocated to Texas.
To where?
North Texas. And then I went back and spent a couple of years in Ventura County going to college.
Okay.
Yeah. And a year back in Orange County with family, and then in Ventura County. So Southern California.
Southern California. Okay. So you missed my bad.
Oh,
my trashing of.
Oh,
Because I'm from the Bay Area.
oh.
You know how we are. But, and maybe you can echo my thoughts. So my frustration leaving California was that everyone I knew did not come from, weren't from California. Everybody I knew came to California, many of them from New York or New Jersey. And the reason they came to California was to define their own identities. Like California is the place, at least when I was growing up there, I don't know if it's still, I haven't lived there. I can't afford to live there. And now, of course, it's like tech stuff. So I don't know what that means. But when I was living there in the 60s and 70s, people came there to find themselves. And it was this opportunity to like try different skins, and there were tons of fads. And so I remember leaving California with a really strong sense of identity is totally fluid. And it's not in California. It's not something that is imposed on you. You just get to make, well, again, this was my experience 40 years ago, but you just get to make it up yourself. And that woman who called me a world citizen, I was heading off to college in Kalamazoo, Michigan. And she said, she had this really interesting idea that I've kind of been playing around with for all these 40 years, which is that people who live, so Sierra Leone's really, really hot. Minnesota, someone's from Minnesota, that was Melissa. It's really, really cold, at least a lot of the time. And so, but California, especially where I was from, so I did not wear shoes for my entire high school, except for gym and lab class, science lab class. You had to have shoes. But I went barefoot. And then I tried that in Kalamazoo, Michigan. That does not work. And so I was talking with this woman after I'd been to Kalamazoo. It was the summer after. And she said, people who grow up in places like Minnesota and Chicago and places that have like actual weather instead of California, they are imposed on by the weather. And so they know that there is external forces that make you behave in a certain way, in a very elemental way. The weather makes you wear warm clothes. So I thought that was I've always thought that was sort of an interesting thing that, you know, if you have external structures, whatever they might be cultural, they might be societal, they might be governmental, they might be weather, they might be having enough food. These things will impose a sense of your identity on you rather than you getting to have the luxury to make them up yourself.
Right.
Anyway, thank you so much for letting me ramble.
Janaki, I want to thank you so much for presenting today. I feel like you brought up this spiritual question for our age: is how do we build empathy? We want to do work of FedEx. What is actually the work that is to build that empathy? So I hope that we that carries with us. I was trying to pull up the next session, but I don't know if I'm going to do it in front of the camera. So go on to maybe we can do it in a minute, let's see. Or maybe Melissa will jump in.
It's Sandy Winters.
It's Sandy Winters. So come back in 2 weeks to hear from Sandy. And Boker Tov, everyone. Good to see you.